Dear viewers, once again I am here to discuss with a new topic regarding the plasma protein binding. Plasma proteins, they are actually the drug reservoirs. In our body we have different reservoirs like in a plasma protein, fats, adipose tissues, and drug reservoirs are those sites where the drug come and bind but doesn't produce any therapeutic effects. So those are the drug reservoirs and plasma protein, and the fats and adipose tissues. They are different drug reservoir where the drug binds without producing any therapeutic effect. So there are today's our learning objectives are by the end of the session we will be able to discuss the plasma protein binding of drugs. What is the plasma protein binding and what is the clinical importance of plasma protein? It is in a very important place in the clinical pharmacology. And what is the effect or what is the relation of this plasma protein binding with the duration of action and plasma half-life of a drug? So these are our learning objectives regarding plasma protein binding. Now there are different type of the plasma proteins, but two plasma proteins, they are very important. Number one is the albumin, and the majority of the weak acids, they come and bind with the plasma protein, that is the albumin, and the acidic alpha 1 glycoprotein is the another where the majority of the drugs they come and bind with this alpha 1 acidic glycoprotein. Now the drugs which bind with the albumin, they are sedatives and hypnotics like the barbiturates and the phenobarbital, uh, thiopental and the benzodiazepines like diazepam, alprazolam and different benzodiazepines. NSAIDs, non-steroidal anti-inflammatory drugs like an aspirin, ibuprofen, indomethacin, they are the NSAIDs which have the strong affinity towards the albumin, and the antibiotics, and among the antibiotics sulfonamides have the very good affinity to bind with the albumin. And on the alpha 1 acidic glycoprotein, that are beta blockers, that is atenolol and the propranolol, methadone, the very strong opioid receptor agonist that have a strong affinity to acidic alpha 1 glycoprotein, and the calcium channel blocker, that is the verapamil. Now this drug plasma protein binding is reversible. The drug might be attached with the plasma protein, it might be detached with the plasma protein. And this is the situation of a drug. This is a drug which bind with the plasma protein, and this is a drug which is in a free form or the free state. And this is the reservoir, the drug reservoir, which maintains the free concentration of a drug in the systemic circulation. Only the drug which is in a free form, we call it as the active drug, because this is actually the drug which leaves this intravascular compartment, reaches the extravascular tissues, goes to the organ, to the target organs, and reaches to the site of action and produces the effect. While this drug which binds with the plasma protein, it remains inside the intravascular tissue compartment, and so it is labeled as the inactive drug. And it is the duty of this plasma protein that it maintains the fraction of the free drug, unbound drug in the systemic circulation. And it's clinically very important. Like in this situation, we are going to see that is the more than 90-95% of a drug is in a free state. That is the active state of a drug. And 10 to 5% of a drug, they are get attached with the plasma protein. So we can say, and we can say in the fractions or in the percentage, that is the 90% of a drug is active drug, is a free drug, and the 5 to 10% of a drug is a bound drug, is an inactive drug which couldn't produce any pharmacological or therapeutic effects. But this plasma protein binding maintains the fraction of the free drug in the system and circulation. So this you can see the width of the arrow. This will show you the magnitude of the effect that depends on the fraction or the percentage of this free drugs. If the more drug is in a free concentration, or more drug is in a free form in the system and circulation, the magnitude of effects definitely is correlating with the fraction of free drug. That much portion of the drug is definitely available for the target tissue, and it binds with the target levels, and it produces the systemic effects. Now that much portion or the fraction of the drug is now available for the metabolism. That much fraction of the drug is now available to the liver for the metabolism, for the biotransformation. And this drug, which is metabolized, and that much portion is now available for the excretion from the kidney. The kidney eliminates, excrete that much portion of a drug from the body. So what is the clinical importance of this plasma protein binding in case when the free drug is more than the bound drug? So you will plot a graph between the time and the effects. You can see that the more free drug will produce more rapid effect. This is the 100% of the effect. So very quickly you will achieve the 100% effects, but as quickly as the drug will metabolize and eliminated, excreted out from the kidney, the magnitude of effects decreases, decreases, and decreases. So this is actually the duration of action of a drug in case when the maximum fraction of a drug is in a free form or unbound form. What is the another situation? In this situation, more than 90% of the drug is bound with the plasma protein, that is an inactive drug, and the 5 to 10% of a drug is in a free form, that is being able to produce the effect, that is the active drug. But the magnitude of the effects are definitely decreased. If you compare the width of the arrow with the previous slide, you can see that is this much is the magnitude of the effect. This much fraction of the drug is available for the site of action, for the target tissue, and this much portion of the drug is definitely produces the effects. Not only the effects, but this much portion of the drug, fraction of the drug is now available for the metabolism to the liver, where the drug gets metabolized, biotransformation of the drug takes place, and when the drug is biotransformed, it is most suitable for the elimination or the excretion of the drug. Now kidney eliminates this portion, this fraction of a drug from the body, but this plasma protein bound drug is reversible. It will maintain the active fraction of the drug. How it maintains, that we will discuss later on, but in this situation what you are going to see that these are the effects, that is the drug produces the maximum effects in a prolonged duration, and that much duration is required for the elimination of the drug. So the duration of action of the drug is very much prolonged in case when the maximum fraction of a drug is bound with the plasma protein and the minimum fraction of a drug is in a free form. Now question arises that how this plasma protein binding maintains the free fraction of the drug. So, for example, we administered 100 milligrams of the drug. Out of these 100 milligrams, the bound drug is, say for example, 90 milligrams and the free drug is 10 milligrams. So if we define it into the fractions or in the percentage, we can say that the 90% of a drug is in a bound drug with the plasma protein, and the 10% of the drug is the free drug, and it is the active drug. Now it is the duty of this plasma protein binding, is the duty of this plasma protein reservoir to maintain the fraction of the active drug into the systemic circulation. Now 90% drug is bound with the plasma protein, 10% of a drug is available free in the systemic circulation. It goes to the peripheral tissues, it reaches the site of action, and it produces the effects. It goes to the liver, gets metabolized there, and eliminated, excreted out from the body through the kidneys. Now what happens? Now this bound drug again releases the 10% of the drug in the systemic circulation unbound or the free fraction. Like, now suppose when the 10% of a drug is metabolized out, excreted out through the kidneys, so now the remaining bound drug is 81 milligrams and the free drug is 8.1 milligrams. So what happens now, that if we again describe this in the fractions, that you can say that again the active drug in the systemic circulation is 10%. When this 10% drug gets eliminated out, excreted out through the kidneys, now what happens? Now the 72 milligrams are bound drug. It again releases 10 milligrams, so 7.2 milligrams will be in a free active fraction that circulates into the systemic circulation, and again it maintains the fraction 10% in the systemic circulation. So if you go down, down and down, 64.8 milligrams, then it's 6.4 milligrams, and again it maintains the free drug, active drug fraction, that is the 10 milligrams. And this is the reason behind that why the drugs which are bound with the plasma protein, how they produce the sustainable effects for a prolonged duration, and why the drugs who are least bound with the plasma protein, they produces the rapid effects and eliminated out through the kidneys as rapid as possible. So this is clinically is very important. Now we have two types of drugs. One drug that is bound with the plasma protein, the concentration of a drug is low than the binding capacity. Binding capacity is much more than the concentration of a drug. So here you can say that is the maximum concentration of the drug is bound to the plasma protein, and the least concentration is in a free form. So we can say that the concentration capacity ratio is low. Binding sites are more than the concentration of a drug, and this sort of drugs we call or label them as the class A drugs. And for example, that we have this tolbutamide, 95% bind with the plasma protein, and the 5% of a drug is in a free state. The drug is oral hypoglycemic. That 5% of a free drug is sufficient to maintain the glycemia. And as the 5% of a drug is in a free, so the drug will produce the more prolonged effects. They are labeled as the class A drugs. What is the another situation? In another situation, the concentration of the drug is more than the binding sites on the plasma proteins. Now the maximum drug is bind with the plasma proteins, and some of the drug is in a free state. So such sort of drugs, we can see that the concentration is more than the binding capacity, and so the fraction of the unbound drug, free drug, is more than the bound drug. We label these sort of drugs as class B drugs, and example is the sulfonamides. What is the clinical importance of this class A drug and class B drugs? If we administer the class A drug, for example, the tolbutamide, it binds with plasma protein, 95% bind with the plasma protein, and the 5% is in a free state. This is drug A. If we administer the drug B, for example, the sulfonamides, along with the tolbutamides, means if we administer the drug A along with the drug B, then what happens? That this drug B has a more affinity to bind with the plasma protein. They get attached with the plasma protein, but they displaces this tolbutamide from the binding of the plasma protein. So what happens that you will get the more drug in the free form. Previously, the tolbutamide, which was 95% bound and the 5% free form, now you will get the 95% free form of the drug, unbound form of the drug. So what is the clinical consequences in such situation? That the drug will produce more pronounced effect. The complete pharmacokinetics of the drug is altered. The drug is now in a free form. It leaves the intravascular compartment. It produces more effect. The magnitude of the effect is more and more. So not only it produces the therapeutic effects, but it might or definitely produces the adverse effects. And if the drug's therapeutic index is very narrow, in this situation, it might cause the toxicity. So in case of tolbutamide, definitely when the 95% of a drug is in a free form, it will produces the hypoglycemia. That is for it produces the adverse effect and its duration of action becomes shorter and shorter. So this is very important clinical consequences of this plasma protein binding, and this is very important place of the drug-drug interaction, especially in the polypharmacy. So when one is prescribing the polypharmacy, one should be very much careful about these pharmacokinetics of these multiple drugs. Now, what is the conclusion of today's session? What we have done, that now we are at the level that the plasma protein binding is the more, then the volume of distribution is less. Definitely the drug could not leave the intravascular compartment because of the bigger molecular size. It remains in the intravascular compartment, so the volume of distribution is low, but there is increase in the duration of action, because only the free drug could leave the intravascular compartment, produces the effect, and then again there will be the further release of the drug from the plasma protein binding, and the duration of action is very much prolonged. Another clinical importance of this plasma protein binding, that there are certain diseases or conditions which alter the plasma protein levels, like anemia, like chronic liver diseases, CLD, that is cirrhosis liver, nephrotic syndrome, or the renal failure. Now these are the clinical conditions in which you will find the deficiency of these plasma proteins. And when the plasma proteins are deficient, then definitely it will alter the plasma protein binding. Those drugs normally bind with the plasma protein 95%, and the 5% is a free fraction, but in case of deficiency of plasma protein, definitely the free drug fraction will be more, and again it will produces the therapeutic effects along with the adverse effects, and the toxic effects. So this was all about the plasma protein binding. Thank you very much.